Well, so welcome this evening to this, I think, the second webinar in 2024 from GIEQs on post-polypectomy surveillance. So this is a really important topic and sometimes an overlooked topic in its importance. We really wanted to give it the attention it deserves. So this will be a 2-hour affair, and I'll just show you. So this is our plan for this evening. I don't know if you can see the structure here. Do we see it, guys? The structure of the webinar? Yeah. So we will just kick off with a quick introduction, and then we'll kind of focus on 3 big strands of what we think is important about surveillance. The index procedure, should expect that in about 3 or 4 minutes from now. The interval before performing your surveillance procedure, that's about 8:15. About 8:45, we'll be hitting surveillance procedure quality and what it means to do a surveillance procedure and the intricacies of doing it. And we'll have a decent amount of time for questions at the end of the webinar. So I first want to perhaps stop screen sharing and acknowledge the people here with me. So I'm David Tate, a gastroenterologist, intervention endoscopist in Ghent in Belgium. And I'll invite the others to introduce themselves. And to start with, maybe John, you can introduce yourself.
Thank you, David. Welcome, everyone. I'm John Anderson. I'm a therapeutic endoscopist in Cheltenham.
Roland?
Roland Valori. I'm a gastroenterologist, stroke endoscopist. I also work in Cheltenham.
Lobke? We don't hear you, Lobke.
Sorry, Lobke Zolman. I work in Belgium as a therapeutic endoscopist.
Okay, and then there will be the faculty, and then I'm joined by a couple of the guys from Ghent who have their cameras on. Thank you so much for joining and being part of it. So we have Sander Smeets, just give a wave, Sander, my second-year interventional fellow in Ghent. Thanks, Sander, for joining. We have Andrea Sorge. I don't pronounce, my pronunciation is poor, but he's just joined us in Ghent from Milan. So Andrea, welcome, and just give a wave. Thanks for joining us. And Maria Eva Argenziano, who will be familiar to many of you who have done these webinars before. She is now back in Ghent, and we are the stronger for it. So welcome, everybody. Right, so I think without further ado, we can make a start. Some housekeeping. If you're watching this on Zoom, great. If you're watching this on the website, you're very welcome to either continue watching on the website if you don't want any interaction, but if you want to interact, you can either use the Slido, that's a little app on the right side of your screen on the website, and Maria Eva will be monitoring those questions and shouting them through to me on the Zoom chat so I can moderate them and read them out if necessary. And if you are on Zoom, then you can just put your in the chat. We would ask that you, if you want to interact and want to turn on your video, all the better, but please put your hand up first and we will moderate that rather than just jumping in with video on. Perfect. We are ready to go. Okay, so I'm going to screen share the presentation. We'll start with me for a short period of time and then we'll move on to Roland to carry on. Now, do you see the presentation now?
Yes.
Yeah, okay. So what is this all about? Why is a surveillance webinar something we want to spend 2 hours on? Well, you have to think about the whole context of surveillance. So it starts with a high quality index procedure. We'll come on to that. Then it revolves around how long it is reasonable and evidence-based to wait before that patient gets their surveillance procedure, if you find a polypectomy, or whether or not they need one at all. And then there are, of course, special situations in which you might want to surveil earlier or at different time periods. And of course, during a surveillance procedure, there may be residual polyp. And if you can't find or understand what a scar looks like, then you will not ever be forming an opinion about residual polyp. So maybe it looks like this. You have the index procedure, and the quality of the index procedure is key. Then you have the interval to wait, or how long you wait before your surveillance procedure. And of course, that really is reliant, or the interval that you want to perform that at is dependent upon the post-test probability of further polyps, i.e. what is the chance that based upon your index procedure, you can predict whether that patient will have more polyps or not that need managing, and therefore the surveillance procedure is required. And then the surveillance procedure, when it occurs, well, what should it be? It's not for sure taken for granted that it should be a colonoscopy. Maybe it should be or could be average risk screening, and whatever that is in your country. Is that IFOB? Is that FIT? Is that something else that we've never heard of? So it certainly does not necessarily have to be colonoscopy, and we'll go into that. And then during that procedure, if you have done polypectomies before, you will need to be thinking about looking for the scars of them, and if there's recurrence at them, detecting that, looking for other polyps. And we have this general feeling that by a certain age, people have formed most of their polyps. So are those polyps metachronous or synchronous? Well, probably the majority of them are synchronous, as in they were there when you did your first procedure. They just were either not detected or not managed because it was too much of a burden on the endoscopist or the patient. And the treatment of any recurrence that you might detect. And why is this important? Well, this is important because we don't want to miss cancer. And that is that we don't want to leave something there for long enough for it to turn into a cancer. Of course, colonoscopy costs healthcare resource, is inconvenient to patients, and is not without risk to patients. Significant evidence currently shows that patients with less than 4 small polyps do not have an increased lifetime risk of colorectal cancer, and patients of advanced stage or comorbidity are more likely to die with their polyps rather than of them. And these 3 statements we will come back to repeatedly throughout this webinar. And it stacks up like this, that it's a balance between the risk of cancer and the cost, harm, and inconvenience that could be one of those 3 caused, or all of them, by colonoscopy. Some of this is put together from some of the people on the call, and we'll try and weave in some evidence as we go. So Roland, please go ahead.
Thank you, David. If you could pass, I'll do the next slide, please. I'd like to, first of all, just mention Wendy Atkins. Some of you may not know Wendy, but she was really the world authority on polyp surveillance, or surveillance for polyps. And I worked with her for a good 15, 20 years. And her main statement that she had for us was that for the majority of patients, doing the first colonoscopy well is more important than doing surveillance. Now, there is a small proportion of patients who have a very high risk of colorectal cancer. It's very important to keep on looking at them. But our main take-home message today is do the first procedure as well as possible, or if you can't clear the colon in one sitting, make sure that it's clear before you plan a surveillance in a few years. And I've seen another patient with a polyp that looks virtually identical to that, who for one reason or another never had it removed and never had another procedure. And I scoped him, 57-year-old chap, and that had turned into a rectal cancer. And this man needed a full rectal excision and an end colostomy. So a catastrophe for him. But the main message is lesions like this can turn into cancer, and they take a few minutes to remove. Finally, I have a strong view that we should be sharing the decision of surveillance with our patients, not just telling them that they're going to have surveillance. Now, I don't know anybody who does a true shared decision conversation with patients, and most of you would throw your hands up, I guess, and say that's too much hard work. Now, this doesn't hold true for LNPCPs. Obviously, patients with an LNPCP are in a different category, and they are usually a much higher risk than a single pedunculated polyp in the left colon.
That's an interesting thing you said there. In LNPCPs are in a different risk category. I mean, LNPCP is normally defined as a polyp over 20 millimeters in size, right? Or something. So when, according to guidelines, according to the countries, societies, should you stop surveying patients? Well, you can individualize the decision if you follow the American guidelines. I like that, actually. Individualize the decision to continue post-polypectomy surveillance if greater than 75. I think that says pretty much everything that we need to know. ESG goes 80, BSG goes 75. So if we talk about the index procedure, what is determining polypectomy completeness? Well, there's technique. So you have your snare placement, your rim of normal, you have margin of normal, and that's very important. And it doesn't just matter if that's a cold snare polypectomy, a hot snare polypectomy, your technique really matters. Here we show again the fried egg principle is exactly the same thing. Here is a hot snare polypectomy, and you can see we just published this in GIE actually. You can go and check it out this month, that there is residual polyp on an area of unresected muscularis mucosa here.
And in the endoscopy last year, the group of Marie Pellissier even did a study with LCI, so Fuji film, and they also have the same outcomes with LCI, with a high negative predictive values, high accuracy for finding recurrence within a scar. Okay, next slide.
Well, I think this one makes your point, no, I mean, about the flat recurrence. I think we should just consider this image. There's blood on it. It's a bit confusing, maybe drawing your eye away from the actual problem, especially in virtual endoscopy. There can be a problem. There's something here for sure, but only once I start seeing this and looking back at this do I think, well, maybe that's something. Is that what you were meaning about flat recurrence being easier to see with virtual endoscopy?
Yes, for sure. That's definitely a nice example, but there are other examples that we've seen in real life where very flat recurrences are definitely better seen with NBI.
And on that note, here are some more.
Just a few examples, yeah. Usually unifocal, sometimes multifocal, so in different places within the scar. So there is definitely a thing with flat recurrences versus more elevated ones, and you can find them both at the edge or in the center of the scar.
I think it's worth pointing out here that multifocal for me is a marker of very bad technique in the prior EMR, and usually don't see in this cohort that we published in Gut earlier this year. Late last year. The multifocal was at the start of the experience, and as the investigators got more experience, we rarely saw multifocal, and the unifocal size decreased. So it's common to have one spot of recurrence if your technique is good and you had a big lesion. It was all very difficult. But yeah, multifocal is usually a marker of poor technique. So we wanted to discuss this one a bit, didn't we? I think when we talked about it, and I don't know whether you see this. Yeah, why don't you go ahead? I mean, there's all sorts of. This is Marie-Eva's.
One second. I'm also on call. My phone's ringing. 1 second.
You go and be on call, and I'll do it. So Marie-Eva, why don't we talk about these? So these are your slide from the Gut article. Goes to X for a number of examples. I think you look through goodness knows how many images of recurrences. I mean, you have these are all recurrences. I think that's right in saying, isn't it, Marie-Eva? They're all recurrences, and these are very different morphologies of recurrence, from extremely flat, maybe even serrated here, extremely subtle on the edge of a scar here. The only clue in white light is the nodularity. Maybe we can even get closer. This is a really high res image. Then here, difficult to see it here. Do you see it here? And then maybe it's here and here, but it very clearly, it's easier to see. There it is, like in white light, very clearly easier to see in narrow band imaging in this case, but virtual endoscopy than there's something here for sure, and that is just invisible on the white light image. Then here, this, I mean, what we think about this is an extremely difficult scar to interpret, but probably here there's almost multifocal recurrence present. The bleeding a little bit maybe gives it away there. Then you have this. This looks serrated quite a lot. Serrated recurrence in a scar, like it almost grows over the surface of the scar. Do you think?
Yes, very hard to see it, to be honest. I mean,
Yeah,
I think here I think you may have added new focus to the
for sure.
equation, and I think it definitely adds value in this case.
These
See
ones
how
are not so.
inconspicuous they can be.
Yeah, I mean, these are not so hard. I mean, this is not something you would miss, is it? In fact, the scar is tiny and the recurrence is huge. Again, indicating for me another marker of poor technique at the original procedure. Very difficult to see here. Maria, any ideas where this one is? Very difficult to see.
Yeah.
And there's this multifocal. Is it up here? Difficult.
On the left side, I'd say.
Yeah. Okay. Yeah. This one's obvious. Appendiceal orifice, and but much more obvious in narrowband imaging than white light. This one is again much more obvious in narrowband, but it's for sure here. One on the edge here. This is a nice one. Lobko, you want to speak to this one?
Yeah, this is underneath the clip. I don't know, but I think we have some slides maybe on clip artifact, we call it.
We do,
And
but this is not clip artifact, I think, right?
no, but the thing, you have to make the difference between the clip artifact and actually recurrence or underneath the clip, which is the case definitely here. But we'll come back to it in a minute. Yeah.
Yeah, so this is recurrence, and it is recurrence because it has this different pit pattern around it. We'll show you what normal clip artifact looks like. There's an example of multifocal recurrence. So obviously the original lesion was not very well removed. Yeah, lots more examples, and you can see them in the article in Guide if you want to go look at it. This sort of thing, if you see this, you can surmise that the original polypectomy was not done very well. That's one from the article. Any other interesting ones here? Another
one maybe.
Which one? This one? W.
This one above it. S and the one left to it.
What is interesting about that one for you?
No, the one left to it.
This?
I think here very flat recurrence again. If you look at it under white light, you hardly see it.
And indeed, it's very, very invisible here, isn't it? Like almost completely invisible in white light. Yeah. Okay. Well, I mean, I really want to congratulate Maria for that slide. That's really an incredible achievement, and I think it's we've just spent 2 minutes discussing it. So any pitch you can look at for 2 minutes is worth it, I think. So look at clip artifact.
Okay, so clip artifact, the name says it itself, the lesions that have been clipped at the index procedure. The scar may have some extra granulomatous tissue forming around it, leaving an elevated scar without actual change in pit pattern suggestive for adenomatous recurrence. So we know that when we clip those lesions in about 35 to 40% of patients, there will be clip artifact. There is an article by Rex's group which says it's lower. It's probably around 10%. Depends a bit on the reason why you clip. Apparently, we saw that for when you clipped it for reasons of prevention of bleeding. Where you actually try to close the entire defect, that you will have a higher chance of clip artifact than when you, for example, partially close a perforation with a new defect. You actually follow the same approach as you do with flat scars or non-clip artifact scars. So you also look for this transition point. But important here is that we tend to remove the clips with a snare or a forceps, so we can see it better. Disadvantages might bleed a little bit, so always inspect before you remove them as well. But if you're gonna have to treat them, you will definitely have to remove them anyways. So to your left, I think definitely at the bottom you can see nicely that this is just a clip artifact. There is no recurrence there. The pits are just wide as we see in a normal scar, and there is no evidence that there is kudo type 3 or 4 adenomatous tissue there. And the second, middle, we've already showed you that image, but there is clearly a transition to an adenomatous pit pattern at the top clip, while at the bottom clip we have a normal clip artifact. And then on the right hand side again we have transition to a adenomatous pit pattern, which I find actually easier to see in the white light this time. I guess you can't really zoom in, but
Sure, we can.
remove that
What do you
clip.
what do you want to zoom in on? This?
The right one. Oh,
this?
yeah, see, so if you look at it, this is not the wider pits that we expect with just a normal scar. And I see that next is a video of you detecting scars.
This is a nice video, I think, of the whole thing that you've just discussed. So it's clearly a scar. It's in one of our courses. You go check out the whole video on GIEQs Online, still there, even though it was in 2021. So we've got closed pits, open pits, nicely shown here. And then as we skip on a bit, we can do underwater imaging, and it shows that it may be the same. Here, you can very clearly see the scar morphology, the paleness, and then we have a clip here. So the question is, what does that show, that clip? And I mean, I don't know, we've got on.
This looks a bit different to the other examples of clip artifact we've just shown. So maybe you can start a little bit when you see this sort of thing. You think it's ulcerated, you think you've lost your pit pattern then, but those are usually also granulomatous tissue and not recurrent or worst case cancer. So when you have clips,
it is for sure granulation tissue. You see it if you usually you see it if it's either a very big lesion or that you have not waited long enough.
Early surveillance,
yeah. I think, and that's real around what we were talking about earlier about, but not waiting long enough. You see this, and then what is it? Well, is it something? Is it nothing? This is the bunched up sign of standard clip artifact, of course, and then maybe we have a better image here. I don't know. Yeah, so indeed we have a raised zone with open pits. We have granulation tissue, and the clear presence of the clip is, clip artifact. It's a bit of a giveaway. This is maybe the nicest type of image you have in this video of bunched up edge, central granulation tissue. You don't always see that, but you sometimes do, and then the clip sitting in the middle. Okay, and finally, biopsies and whether biopsies are necessary. I think this is the other study you were talking about, isn't it? The ESCAPE trial. You want to talk to this one?
Yeah, so the conclusion of this study is actually when you have a high confidence that there is no recurrent at the scar, that with using narrowband imaging and you focus, you can get to 100% negative predictive value. So basically what it comes down to, and also the other studies that I've mentioned, Felices, there's another Spanish study published in endoscopy in July last year, our study. The thing is that what you need to do is just continuously monitoring, definitely at the start. You take biopsies of every scar and you decide for yourself, have I got high or low confidence? Is this recurrence or not? And you follow up on your biopsies. And once you get to these high negative predictive values yourself, I think you can stop biopsying the scars. And this is what all these studies also have shown, that the high negative predictive value can make you abandon biopsying the scar, basically. There is maybe one little thing that I found of note is that I don't have images of it, but I don't know if many people use all-rise but it has been published as well that when you have done your initial EMR and you lift it with all rise as a lifting solution, that at first surveillance, that you might also see a raised scar, not just a normal flat scar we are used to seeing, but also definitely some nodularity there.
Yeah, but this of course is now withdrawn, isn't it? So I think we will not be seeing that anymore. John,
Hopefully.
let's level here. I mean, you've seen these great results, 100% negative predictive only for scar assessment with narrow. So what's the problem with that for you? I mean, you know, is this real life or?
So the problem with that is if you get it wrong. So for someone like Lob, that's not going to occur. And I think there is a learning curve. And Lob's mentioned it. But if you're unsure, and some people have great difficulty in differentiating recurrence versus granulation tissue, and it can be difficult. It has been difficult for me. I think you're better to biopsy the site. And if you're going to do that, you probably need to biopsy and do some STC. We're going to come on to that in a moment. And that's probably safer. And then if that comes back as granulation tissue, then firstly, there's a bit of education for yourself. You can supplement that by accessing some of the things on GIEQs. But secondly, it's a certainty for the patient that the lesion is completely gone. I think if you are unsure and you leave it and it continues to grow, it's not going to make it any easier as time goes on. And of course, if the patient gets discharged, it can grow and then progress into a cancer. And if it's a rapidly growing thing, it can occur, the development can occur very quickly. So I have a feeling that some of these lesions, when we remove them, we seem to stimulate some growth or tropic factors within the mucosa. And some of these lesions regrow incredibly rapidly and actually grow to be bigger than the original lesion in a very short space of time. So understanding what a scar looks like, being able to confidently assess it and be 100% sure that it's clear is a skill you need to acquire. It will require some training. And I would encourage you to look very, very carefully, have very good images. If you're unsure, take biopsies and then check your histology so you can match it with the images that you've taken and make use of the online resource that we can provide.
I think another problem, and I don't know, Lopo, what do you think about this, is that all of this publication stuff that we show you is where we have the evidence, so we need to show it, but it's all from experts, right?
Yes, and it shows in the incredible high NPVs overall. All of them actually have the same outcomes, but they're all in expert studies.
I mean,
so if I come back to you, David, we have you've got a similar practice to mine. So finding a scar requires a bit of skill as well. So historically, I used to put a very small tattoo either side of the large resection site, not involving the edge of the resection site, but away from it. And then when I came back, the scar should be between the tattoo marks, the two tattoo marks, right? And the scar should be between the two tattoo marks. Because I'm reviewing my own practice now, I don't do that.
And then finally, we come on to a question which someone asked us, which it says, often recurrences, pit pattern looks to me distorted. So I would say irregularly regular. So my question is, how safe are we to do cast? So John, I think that leads very nicely into the next part and the final part. So we've got about 35 minutes left. And I'll hand it over to you, John. I think we can see the slides. So we talked about all this. We're now going to talk about how to treat recurrence when it occurs. I think the final thing I wanted to mention with this slide was that these synchronous polyps, if you want to know how to manage them, look at that other nice webinar we did recently. Okay, John, over to you.
Right, recurring nightmare is true. So I'm getting a lot of referrals now with scars, unfortunately. And in fact, I have some of my own recurrences as well. They do occur if you do a sufficient volume. And are they a recurring nightmare, or do we have a strategy for dealing with it endoscopically? So you've seen some of these pictures, so we'll not dwell on this. But the problem with the scar recurrence is that it's very challenging and it's very time consuming and probably requires repeat procedures, because if you treat a scar, you're obliged to review that area again because it's more likely to recur than if you've just done something de novo. And the question, of course, is it unnecessary? But the issue I want you to think about is if you're doing a surveillance and there's a scar recurrence, and you're myself or David, do we build in time to deal with our recurrences? Or do we simply say there's a recurrence, we need to rebook it and have a longer time slot? Certainly, if it's going to back into the periphery and they come across a scar recurrence, then they're going to refer it back to you. But something to think about in terms of booking. Next slide. So there's no doubt that polyp recurrence is a misnomer. It's an incomplete resection of the index lesion. That is what it is. And there's no doubt that prevention is better than cure. And the slides in the bottom just show a lesion we did recently. And the soft tip so there's a couple of things here. The diligence in resecting the original lesion, being sure that you remove all the macroscopic tissue. So all the endoscopically visible tissue has to go. And then you have to have complete STC of the whole lesion. Okay, and David's just mentioned this. So if you've got incomplete STC, your results are going to be less good. So the key things here are prevention better than cure. Next slide. But of course, you may be concerned about incomplete resection. And David's just alluded to some of the things that I've got on this slide here, where you think, oh, have I really got it all? So to help with that, take multiple clear images of every post-index resection, whether it's small or large. So for each polyp you remove, you'd have a pre-image and then a post-image. And that becomes very important when you have larger resections. You should have images of the whole site. If you're not sure you've removed it all, you can then consider referring on then. And I would suggest that if you're not sure you've removed it all, an early repeat might not be the best course of action because it becomes very difficult to separate the granulation tissue from the more mature scar with recurrence. And I have shifted my practice from a 3-month surveillance strategy out to 6, and I agree with David. The issue comes if you book for 6 months and you've got problems with service and waiting times, and the 6 months drifts out to 8 months, drifts out to a year, you've got a problem because the interval's getting longer and longer. And certainly if it's a distal lesion and the idea was you're doing a scar assessment at 6 months and it's drifted out to 12 months, I'm now saying to my bookings team, well, yeah, we need to facilitate this patient's surveillance, but I'm going to switch it from a flexi-SIGI to a colon because I'm not now just interested in the scar. We now have got a surveillance issue. The other thing to think about incomplete resection is the pathology in the resected specimen. So if you think you've got on block and the pathologist tells you it's not an R0 resection, you've almost certainly got recurrence. And then obviously if you've got adverse pathology such as malignancy present within the polyp, but you think you've got completely resected, you might want to think about, do I need to go back? Because obviously the implications for the patient are significant. So that's a time when you might go outside of your surveillance guideline and come back a little bit earlier. And if you're not sure that you've got it all out, another reason for referring to maybe if you've got one, a polyp MDT. And I think if you're thinking you've got incomplete resection, you need to have that discussion with the patient. Next slide. So the take-home messages are, it is difficult, but it's not a nightmare. And the prevention bit is your responsibility. I think the surveillance intervals are critical. And I think if you think you've got potentially incomplete resection, you need a 6-month surveillance. And you need to have a plan whether or not you're going to try and remove the recurrence then, or advise the patient they may have to come a second time. If you're going to do that, you need a competent endoscopist doing that procedure.